Good afternoon, and welcome to today's webinar, Recovery After Critical Illness, the Role of Nutrition. My name is Bethany Hopkins. I'm a Medical Affairs Manager with Nestle Health Science, and I will be the moderator for today's session. Before we get started, I would like to go over a few items so you know how to participate in today's event. As you can see from the image on the right, we've taken a screenshot of the attendee interface control panel. You should see something that looks like this on your own computer desktop in the upper right corner. The first thing I want to draw your attention to are the audio options. If you've joined the presentation listening using your computer speaker system and would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. Next, should you require technical assistance, please type your question into the question panel to the right of your screen, and our Citrix representative will assist. You will use the same question panel to ask questions at any time during the session. As a participant, your audio is automatically on mute. However, you will have the opportunity to submit questions. And I will be collecting all of these questions for Lesley, who will address them at the very end of the presentation as time permits. There are 3 handouts for today's session. One is the presentation slides, the other is a comprehensive reference list, in addition to a certificate of attendance. You will notice on the handouts that there's unpublished data Lesley is going to be sharing today, which has been removed from the handouts. All 3 of these handouts can be downloaded directly from the server. We understand that some participants are currently having difficulties accessing the handouts, and we are looking into the best option to share these with you after the session. And lastly, I would like to note that today's session is being recorded. Now, it's my pleasure to introduce our presenter, Lesley Moisey. Lesley Moisey is currently completing her PhD in Physiology and Nutrition at the University of Waterloo and London Health Sciences Centre. Her doctoral work aims to comprehensively evaluate changes occurring in nutritional status, body composition, and functional ability in survivors of critical illness, and to further explore barriers specific to this population in achieving optimal nutrition. Lesley is particularly interested in the development and implementation of integrative nutrition and rehabilitative therapies in the acutely ill to improve outcomes. Prior to returning to doctoral studies, Lesley worked as a medical surgical dietitian in acute care and completed her Master of Science in Nutrition Sciences at the University of Guelph. Lesley is able to weave her clinical experience into her academic work, which has many positive implications for her future research, contributions to our field of nutrition and medical nutrition practice. I've had the pleasure to see Lesley present on a number of occasions. Her passion is evident and her knowledge is inspiring. She's a wonderful nutrition ambassador and pioneer in this growing field of nutrition and its role in the recovery process. Today, Lesley will be talking to us about recovery after critical illness, which is a topic near and dear to her heart, and I dare say many of you that are on the phone. And she will be sharing with us, for the first time, findings from her doctoral work. I will now turn the floor over to you, Lesley.
Great. Thanks, Bethany, and welcome to everyone. First, I'd like to thank you, Bethany, and Nestle Health Sciences for inviting me to present today on a topic that, as you mentioned, has become very near and dear to my heart. And while I have a ton of information I could have covered today, I had to eliminate some, and you will see some extra slides have been provided on your handouts, and as well as Bethany mentioned, a comprehensive list of references. And so I don't have any conflicts of interest to declare. And today, if you can take away anything, I have 3 learning objectives for this presentation. The first is that I hope you will be able to define or state the core components of post-intensive care syndrome. I also hope you'll be able to identify common barriers to adequate nutrition in survivors of a critical illness, as well as identify 3 strategies you can implement in your practice to enhance recovery in this group. So I thought I would get started talking a little bit about critical illness in Canada. And the critically ill are really a unique subset of hospitalized patients. In 2013-14, there were just over 200,000 adult ICU admissions in Canada, although although this data does exclude Quebec. And about 1/3 of those admitted to ICU required invasive mechanical ventilation. Now, despite the high severity of illness experienced, in ICU mortality is less than 10%, and furthermore, over 80% of patients requiring an ICU admission will survive to hospital discharge. So I think the take-home message from this slide really that I want to convey is that despite a high severity of illness, with the advancement of new technologies, new therapies, and so forth, patients are surviving, but we need to remember that survival is not necessarily indicative of quality of life. And furthermore, as you can see here, the economic impact of treating a critically ill patient throughout the trajectory of care is quite substantial. So over the course of this presentation, I will be referring to certain points along the quote-unquote trajectory of care in the critically ill, which I've defined here for you just for reference purposes. But before we get too far in, I'd like to get a sense of who I'm actually presenting to today. So here we have within the webinar the opportunity to do some polling questions. And if the first poll can be presented, I'd like to know who the audience is today. So do you work with hospitalized critically ill patients? And if so, at one point along the trajectory of care? And I recognize a lot of individuals are probably sitting in group presentations, so feel free to select multiple. And what I'd like to emphasize on the third point for yes, both in the ICU and following ICU discharge, here I'm trying to gather how many individuals regularly as part of their practice follow patients in ICU and continue throughout ICU discharge. And this is regularly versus just perhaps on a coverage basis. So I'll give you guys a few more seconds to complete this. Okay, can we go ahead and pull up the polling results? Okay, so this is great. It's a really interesting mix of individuals, and I'm glad we've attracted a number of individuals who work both with ICU patients and who don't work with ICU patients. And so I think this is going to be really exciting. Now we're going to move on to the next slide, and actually it's another question. I won't be asking too many, but I'll be question heavy on the top of this presentation. I'd also like to know, are you aware of the term post-intensive care syndrome? And that would be before you got to see the handouts for this presentation. And would you be able to state its three core components? So let's go ahead and run that poll. And can we see the results of the poll? Okay, so this is actually really exciting for me because I can share some information, and hopefully today you will recognize how unique the critically ill are. So let's go ahead and go to the next slide, or back to the slide. Okay. Perfect. So post-intensive care syndrome, or PICS, as I might refer to it later today, really refers to a constellation of health-related morbidities experienced by many survivors of critical illness across three broad domains. And this includes physical impairment or functional disability, cognitive impairment, and perturbations in mental health. The functional disability is largely driven by ICU-acquired weakness and loss of muscle mass and muscle strength, resulting in the inability to perform activities of daily living. So one more question on the top, and then we won't have any more, and we can go ahead and run the poll. But this question is, have you heard of the term ICU-acquired weakness? I'll give you guys a few seconds to answer that. Okay, and let's go ahead and see the results of that poll. Okay, so about a 50-50 split. And let's go to the next slide, please. So the definition of ICU-acquired weakness is a clinically detected weakness in critically ill patients in whom there is no plausible etiology other than critical illness. Now, not all critically ill patients are affected by ICU-acquired weakness, and risk factors are typically related to a higher severity of illness or individuals who have a prolonged length of stay, require mechanical ventilation for a longer duration. However, the effects are significant, and ICU-acquired weakness has been associated with a number of poor clinical outcomes, and this includes limb and respiratory muscle weakness, difficulty weaning from the ventilator, short and long-term functional disability, decreased exercise capacity, and decreased quality of life. And on your reference sheet, and I'll just circle the reference here, Batt et al. Jane Batt actually wrote a very thorough summary on ICU-acquired weakness. So if you'd like to learn more about it, particularly around the molecular and physiological underpinnings of this syndrome, I highly recommend referring to this document. So the extent to which functional disability occurs after critical illness is exemplified by seminal research led by Margaret Herridge and the Critical Care Trials Group in Canada. And this group of researchers followed a cohort of 109 survivors of acute respiratory distress syndrome for up to 5 years following discharge from ICU. And I think what's first important to highlight is that this group of patients was a very young group of patients and healthy at the onset of illness, with most of them having none or only one coexisting condition or comorbidity. So this graph is a survival curve, but I'll have you focus here on the highlighted numbers. And essentially what you can see is that, again, survival rates are quite high. So 1 year following discharge from the ICU, 89% of patients survived. However, when they followed these patients 5 years out, only 68% survived. Now, more striking is that 1 year after discharge, only about half of these patients had returned to work, and many in a lesser capacity, so meaning maybe part-time instead of full-time. And even 5 years out, only 75% of these individuals had returned to work. And again, remember, this is a very young, healthy group at the onset of illness. Now, furthermore, 5 years out, patients were performing below expected on a 6-minute walk test, which is a fairly standardized functional measurement that's often reported, particularly in the literature. Now, in addition to impairments in physical function, ICU survivors may also experience cognitive impairments, and these would include delirium, agitation, memory loss, or deficits in executive functioning. And the mental health perturbations that they experience are also a significant concern, such that a large proportion of ICU survivors will experience depression, anxiety, and even up to a third of patients have been found to have post-traumatic stress disorder directly related to their ICU admission. And that finding to me is very striking, particularly about the state of these individuals as they come out of the ICU. So it's clear that the recovering critically ill are a very unique patient population, and a lot of work has been devoted now to developing strategies and interventions to enhance recovery, but the role that nutrition plays in this process is unclear, and relatively little attention has been given to this area of research to date. So for the remainder of this presentation, I'm going to provide a brief overview of what we know about the nutritional state about the critically ill throughout the trajectory of care. I'll then talk about a brief theoretical basis as to why optimizing nutrition care could enhance recovery. And then I'll talk more about the barriers that have been identified in achieving optimal nutrition post-ICU, as well as some strategies we may be able to implement. Okay, so I have another polling question here, and we can bring up the poll right now. And as you guys are filling out this question, I just want to let you know that in the extra slides in your handouts, I've actually included a couple that summarize the subtypes of malnutrition in which there's fairly universal consensus. And there's also a slide that outlines the Aspen A and B criteria for diagnosing malnutrition. And I do want you to know that different bodies, so this would be Aspen, ESPN, the Canadian position from the Canadian Malnutrition Task Force, do have different criteria for diagnosing malnutrition, but a central feature across all of them is looking at changes in body composition, and in particular, we're talking about a loss of lean body mass or muscle mass. So I really want you to keep that in mind as we progress throughout the rest of the presentation. Okay, so let's go ahead and look at the results of this poll. Perfect. This is great to see. I know the Canadian Malnutrition Task Force would be very happy to see almost 3/4 of you using subjective global assessment, as that is the recommended method for identifying malnutrition in hospitalized patients. Certainly to a lesser extent, I see we're using anthropometrics, which we know aren't always reliable in hospitalized patients. Hand grip dynamometry, not so much. Ultrasound, which I'm sure many of you have heard about, right now is more of a research tool, and CIA. Perfect. So let's continue into the next slide. Okay. So to date, there have been several studies that have examined the prevalence of malnutrition using SGA at the time of ICU admission. And what we see here is prevalence of malnutrition is relatively high, and it has been associated with poor clinical outcomes, namely an increased mortality. But I think it's really important to recognize that completing a subjective global assessment at the time of ICU admission does have its limitations. So first of all, you're relying on proxy reporting predominantly by family or caregivers, particularly as many ICU patients at admission are not conscious or capable of providing any information. And then in particular, SGA is also limited in that it's unable to accurately detect severe muscle wasting, particularly in obese patients. And often changes in muscle or muscle wasting really can't be identified by physical assessment. And again, that's how body composition is subjectively assessed using SGA. Now, skeletal muscle mass can also be estimated using CT, and this is largely a research tool and not practical in clinical practice, particularly as obtaining a cross-sectional CT image taken at the third lumbar vertebrae, which is required to do this analysis, isn't often done in this patient population, or at least on a regular basis. However, using this technology, both our lab group as well as our Danish colleagues have demonstrated that at the time of ICU admission, low muscularity in both an elderly population and adult population is highly prevalent, and it has been associated with poor outcomes. And again, this includes increased mortality, decreased ventilator-free days, so more time on the ventilator, and an increase in both ICU and hospital length of stay. Okay, so during ICU admission, nutritional status likely continues to decline. And we do know, based on the international survey data, which I'm sure many of you who work in an ICU have participated in, that's run by Darren Halen's research team, is that adequacy of protein and energy intake in relationship to what is prescribed is very poor. Individuals are usually getting about 2/3 of what's prescribed. And this is actually despite numerous guidelines that exist for feeding the mechanically ventilated patients. Furthermore, the acute phase of critical illness is dominated by a highly catabolic and pro-inflammatory state, which, combined with immobilization, delivery of certain medications, drives significant depletion in muscle stores. So Zidane Kouthakhieri and colleagues published this work in JAMA a few years ago, and here they measured muscle loss by analyzing the change in rectus femoris cross-sectional area, and this is a muscle group in the quadriceps. And they did this using ultrasounds in patients with both single and multiple organ failure. And so what you can see is patients with multiple organ failure here in the dark circle have a steep rate of muscle loss, losing just under 10% of that cross-sectional area within the first 3 days of ICU admission and almost 16% by day 7 post-ICU admission. So I think a take-home message from this slide is to really emphasize both how fast and how early muscle wasting occurs relative to the onset of critical illness and ICU admission. So before we transition to talking about nutritional status in patients following liberation from mechanical ventilation and ICU discharge, I would like to ask another question. And we can go ahead and bring the polling question up. But this question is, do you feel an ICU admission should be an independent risk factor when evaluating the nutrition risk of patients on a ward? And you can select from yes, no, or only if the patient who was transferred remains on nutrition support on the ward. Okay, can we go ahead and pull up the results? Okay, well I'm happy to see that result, and hopefully I can continue to convince you on the rest of the presentation why I do feel it should be an independent risk factor. Let's go ahead and go back to the slides. Okay. So what do we know about nutrition care and adequacy of nutrition intake in the recovering critically ill? I'm going to tell you right off the bat, we don't know a lot. And despite hundreds of studies that exist and have been published that examine nutrition and feeding in mechanically ventilated patients, there are less than 20 that have actually looked specifically at nutrition recovery following liberation from mechanical ventilation or extubation. I do realize both of those terms, they're different, but I might use them interchangeably throughout the duration of this presentation. Now, given the high prevalence of malnutrition in the critically ill before they even step foot in the ICU, as I've showed you, combined with both inadequate nutrition delivery as well as the multiple non-modifiable factors related to the physiology of critical illness that are driving muscle loss, it's really clear that this group of patients likely has a high prevalence of malnutrition at ICU discharge or are at very high risk, nutrition risk in recovery. However, we don't have much prevalence data on this because malnutrition is really difficult to actually measure at this point in time reliably in this patient population. Now, in the absence of evidence that shows optimizing the nutrition care and intake of the recovering critically ill improves meaningful patient outcomes, such as improvements in functional status or quality of life, we first need to justify why could nutrition be a key factor in enhancing recovery. Now, I'm sure a lot of you are probably chuckling at this slide. I know I'm presenting to a group of nutrition experts, so it's highly redundant to show you a slide that emphasizes the essential role that nutrition plays in the maintenance of total body health, well-being, and optimal physiological functioning. Now, conversely, I think it's a very good reminder, though, that malnutrition, which we know is highly prevalent in the hospitalized patients, can result in considerable adverse effects, as shown here, on every single organ system, tissues, body composition, functional, and health outcomes. But again, I want to hone in on muscle and functional status, and again, keep in mind that loss of muscle mass is a defining feature of malnutrition. So this next slide here is largely oversimplified, but I do want to emphasize the crucial role that nutrition and protein in particular plays in the maintenance of muscle health. So muscle is a very dynamic tissue, and cellular proteins are continually being degraded and synthesized such that amino acids are taken up from the bloodstream to fuel muscle protein synthesis. And similarly, then muscle protein is being broken down into amino acids which are released back into the bloodstream. Now, the rate of muscle protein synthesis and muscle protein breakdown need to be balanced in order to maintain protein stores and tissue mass. And when net muscle protein synthesis is greater than muscle protein breakdown, then you'll see muscle hypertrophy. And then conversely, if you have a net increase in muscle protein breakdown, then you're going to see atrophy occurring. And I think what's important is to recognize there are a multitude of factors that are driving both of these processes. So for example, factors that promote muscle protein synthesis, well, we need an availability of substrate, both protein, I have leucine here, which is the branched chain amino acid, calories, and activity stimulus will enhance muscle protein synthesis, as well as various hormones. And something to keep in mind in the critically ill, though, including in recovery, is that many of them are often insulin resistant or experience anabolic resistance, which is decreased sensitivity at the level of the muscle to amino acids in driving or stimulating muscle protein synthesis. Now, in contrast, factors that promote muscle protein breakdown, inflammation, both acute and chronic illness, immobilization or inactivity, low nutrient availability, as well as a number of medications. And as you can see here, when you look at the critically ill, pretty much every one of these factors they are affected by. Okay, so what do we know about protein and energy intake in the recovering critically ill following liberation from mechanical ventilation? Well, the first study of only a few that examined this was published in 2010 by Sarah Peterson and colleagues, and they examined protein and energy intake in patients who were receiving oral diets only. And they evaluated this using a 24-hour recall method. Intake was assessed for the first 7 days following liberation from mechanical ventilation. Now, they also assessed adequacy of intake, and they did this by comparing intake to standardized prescriptions, standardized equations, so 25 calories per kg and 1.2 grams of protein per kg. And then when we look at the results, first I'll just orient you to this graph. So on the x-axis of this figure is study day and then also sample size. And you can see the sample size decreases due to attrition. And the y-axis represents the percent of daily requirements consumed. Now on the lines here, they also have net consumption of both calories and protein. And so what you can really see is that over the course of the study, the patients never consume above half of their prescribed calories, and protein adequacy is even worse, with these patients consuming, around a third of their estimated daily requirement. Okay, so the next thing I'm going to present to you now is some of the findings arising from a prospective observational feasibility study examining a number of different facets of nutrition recovery in the critically ill that I've recently completed. And one of our goals in this work was to examine protein and energy intake and adequacy of intake in this population, regardless of the mode of feeding. So whether they're on enteral, parenteral, oral, it didn't matter. We recruited patients who had required mechanical ventilation for greater than 72 consecutive hours from a 20-bed med-surg ICU in a large academic center. And our aim here was really to capture a sicker population who may be more likely to experience health morbidities and malnutrition post-ICU. We assessed intake using weighed food records, so we went and we weighed the leftovers of all food that was delivered to patients. And we also used dietary recall to capture any snacks or foods that were brought from outside the hospital that we might not have weighed. And these photos here just show an example of what we were doing. We also measured the amount of enteral or parenteral nutrition delivered from nursing flow sheets. And I will tell you, actually, none of our patients received or were receiving parenteral nutrition in the study. Now, we also followed patients for 7 days daily following liberation from mechanical ventilation. And we also just did another day 14 measure, as this study is also meant to be a feasibility study evaluating recruitment and retention with the possibility of doing a future larger trial. And then in comparison to the Peterson study, we actually compared intake to what was prescribed by the dietitian versus just the standard set of of equations. So over a 6-month period, we recruited 19 patients, and data was collected over a total of 125 study days. And of course, patients had altered post-extubation hospital length of stay, and 68% of these patients made it to study day 7 and 50% to day 14. Now, all of the data here, you'll see the continuous data, it's presented as median and interquartile range. We successfully recruited a wide spread of ages, which is really nice. Our youngest was 34, our oldest was 85. Now, I've also thrown up the BMI data. So this is BMI based on ICU admission weight, and this was actually an estimated weight. And what you can see here is there's huge variability. However, there's a large proportion of obese patients in this population, including 26% of them had a BMI greater than 40. And I think we need to keep that in mind, because with obese individuals, our usual measures of body composition are less reliable, and they really are a different population in many ways. Okay, so as many of you know, in the days following extubation, patients will often be prescribed a variety of different diets and transition from various modes of feeding. And for our analysis, to specifically look at intake and adequacy of intake based on feeding modality, which I've listed here, we ended up creating 3 subgroups out of the total study days. And these were patients who were receiving enteral nutrition only with no oral diet, those who are receiving enteral nutrition with an oral diet, and those on an oral diet only. And now, because of this approach, intake from a single patient on a different day could be included in any of the 3 groups if they are prescribed multiple diets, although this did prevent us from doing statistics comparing these 3 groups because they're not independent observations. Now, I can tell you that only 2 of the 19 patients we followed remained on enteral nutrition without an oral diet for the whole duration of the study. So what did we show? Well, let's first look at protein intake. So if we lump together intake for all 125 study days, what we saw is that patients consumed a median of 56 grams of protein per day, and median adequacy of intake was only 46%, although you can see there's a wide range here. Again, this is the median and interquartile range. Now, when you look at the proportion of study days for which greater than 75% of estimated protein requirement was consumed, here you see that only 38% of the days this was actually achieved. So again, quite low in keeping with some of the previous findings. But now, why don't we take a look at the data by mode of delivery? So here on this graph, the x-axis represents feeding category, as I described above, and the y-axis will be net median protein intake. And what you can see, and probably not unexpectedly, is that patients who received enteral nutrition had greater intake in comparison to those on oral diets only. And again, when we look at the proportion within each group in which protein adequacy was greater than 75%, what we can find, and I think one of the most striking findings, is that on no study day in which a patient was consuming an oral diet only did they meet more or greater than 75% of their requirements. So you can see this data here is really being driven by those patients on enteral nutrition, and I think this emphasizes a huge problem in trying to get these patients eating adequate protein. Now, our findings for caloric intake and energy are similar as well, and so I'm not going to go over them in too much detail other than to say, again, these findings mimic the protein data. However, you do see that individuals are more apt to consume adequate calories if they're consuming adequate calories at all in comparison to protein. So we then did a pre-planned sub-analysis in which we wanted to explore meal and food intake patterns on days patients were exclusively receiving a regular, and when I say that, I mean a non-modified texture or fluid diet. And our key objective was to first quantify food and liquid waste, as previous studies have shown that in non-critically ill hospitalized patients, about 30 to 42% of foods and liquids that served go unconsumed or are tossed in the garbage, essentially. So we also wanted to then look at calorie and macronutrient intake between meals with the goal of identifying whether patients tend to consume more at a specific meal and perhaps providing an opportunity for dietary intervention. And one thing I do want to emphasize, though, is that at the hospital we conducted this research, patients do have the opportunity to select their menus the day prior, and then if they're unable to do so, a standard diet is provided. Okay, so of this subpopulation, we only had 9 patients. So 9 of those 19 patients in the study were ever prescribed a regular diet at all. And again, similar, we grouped all of our patient data into the total days that a regular diet was consumed, which was 33 days. So again, it's not a large sample size, but this research really is meant to be exploratory. And one of our interesting observations was that at the time of liberation from mechanical ventilation, 7 patients of the 9 had actually underwent a formal swallowing assessment by a speech-language pathologist. And of those, 86%, so 6 of the 7, had been diagnosed with dysphagia and had required a modified texture diet prior to transitioning to a regular diet. And I just want to point out here with these references that dysphagia is a big issue affecting patients who have been who have acquired endotracheal tube intubation, and both of these references here are some good papers. This one in Chest is a systematic review looking at the prevalence of dysphagia post-extubation. Okay. So something that was exciting, I guess I'd say from a research perspective to see, was that the total amount of food and liquid waste, so this is by weight, as well as the total amount of protein and calories that are wasted was 43%. And the reason I say this was exciting was mostly because it mimicked the findings of other studies. However, of course, this is a significant concern given that almost just under half of everything that's being delivered is being wasted. And this really has huge economic implications. So part of our analyses that we did also involved examining the types of foods and fluids that were wasted. And prior to our analysis, we looked at all the foods that were delivered on the regular menu at this particular hospital, and we grouped them into 22 food categories based on similarities in nutrient profile and cuisine. So for example, fruit, sandwiches, starch, yogurt, milk, juice, the protein component of main courses, etc. And then we also added a 23rd category, which was non-hospital foods, and this really refers to foods brought in by families, purchased at retail outlets, etc. Oh, and just in the study, it just happened that none of the patients had been prescribed or received oral nutrition supplements. So when we looked at waste by the food categories, for only 5 of these 23 categories was 30% or less by weight wasted. But interestingly is that the category in which tended to be less waste were the non-hospital foods. But I want to point out that the nutrition quality of the foods that brought in was not necessarily that great. A lot of it was, from the coffee shops in the hospital and tended to be higher in fat and refined sugar. And so, let's keep this in mind as we continue to progress. So next, what I wanted to do is look at how protein and calories provided and consumed measured up when we related it to weight. So how many grams of protein or kilo or calories per kg body weight did what they were taking in translate to? And part of the rationale for doing this was that previous studies have shown that, or looking at high food waste, have concluded that this high waste contributed to low intake because what was provided met requirements. However, what we found wasn't the case. So here I have a graph for protein intake, and you can see this is how much was provided with in relationship to each individual patient's body weight. This is data from each of the 9 patients. and then what is consumed. And I'll throw the energy data up there as well. The dotted lines here represent what I would technically consider maybe a minimum threshold requirement. So 1.2 grams per kg protein, 25 calories per kg calories. And again, these are really minimum thresholds. And really what you see here, though, is that the amount of proteins these patients are consuming is, quite frankly, grossly inadequate. So here you have 6 of our 9 patients. No, I lied. 7 of the 9 patients here were consuming less than 0.6 grams per kg. So very inadequate. And on the other hand, though, it's also clear that even though they're not being provided with what they need, clearly in the setting of so much waste, an appropriate intervention would not be simply just to provide more food. And this really highlights, I think, the conundrum for feeding a recovering critically ill patient and the need for us to become very creative in the development of strategies to enhance intake. Okay, now I recognize we're coming near the end of our time. So just to show, we actually didn't see any differences between intake, between caloric or macronutrient intake between meals. However, one of the advantages of having a small sample size was that we can look at individual data. And once again, we produced these spaghetti plots looking at individual protein and caloric consumption at each meal and snack. And so what you can see here now is that there's considerable individual variation in that some patients are consuming more at lunch, others at dinner, etc. And as clinicians, I think it's really important that we be mindful of this individual variation and the importance of tailoring nutrition care plans to the individual. So what do we think is driving poor intake? So have a look, and we can pull up the poll here, but what group of factors do you think would most impact a recovering critically ill patient's ability to consume adequate nutrition? Would this be the effects of illness, food and mealtime barriers, organizational barriers? And I want you to think about what you think would most impact intake. So can we pull up that poll? Perfect. And let's go ahead and see the results. Okay, so a good mix, and without a doubt, all of these are going to be barriers to eating. Now, with the critically ill, though, and let's go ahead to the next slide. Although there have been less studies looking at barriers to eating and recovering critically ill than there have been generally in the hospitalized patient, really what often comes up more frequently is these physiological or the illness-related effects that are barriers. And really, again, this emphasizes the challenge in getting adequate nutrition into these patients, because to some extent, these barriers, whether it's poor appetite or nausea and vomiting, taste changes, they're not easily modifiable. So what can we do to improve intake in this vulnerable group? And I think the first thing that we need to do is recognize that the critically ill, they're a vulnerable patient population, and they're very different than your typical medical surgical population. And again, think about post-intensive care syndrome, ICU-acquired weakness. We also need to consider that likely after an ICU stay, you're probably malnourished or, again, very high risk. And enhancing nutrition recovery requires a multifaceted and multidisciplinary approach. Okay. So I think in discussing how we improve nutrition care, I want to talk a little bit about the transition of care. So by definition, ICU transitional care, it refers to the care provided before, during, and after the transfer of an ICU patient to another care unit to ensure minimal disruption and optimal continuity of care. And compromised transitional care has been associated with, again, increased negative clinical outcomes. Now, our last poll is, I just want to ask, at your own hospital or institution, do you have a team that follows ICU patients throughout the transition of care? Some of them, they're sometimes called a critical care outreach team or similar. So let's go ahead and pull that up. And why don't we look at the results now? Okay, so a large proportion clearly do not. And I want to talk a little bit about, why this could be a concern. So why don't we go back to the slides now, please. And just to our coordinator, I do recognize we have about 10 minutes left, so I will wrap up here shortly. So some really great work that's come out of the UK by Judith Merriweather has examined nutrition recovery in the critically ill from doing qualitative research, and has shown that nutrition recovery is hindered by poor transitional care. So what do they mean? So often they found that patients coming out of the ICU, there was limited nutrition documentation provided upon transfer. As well, interventions that impacted nutrition were implemented prior to formal assessment by a ward dietitian or a nutrition professional. And ward practices or ethos were very different. And a central observation is really that ward staff lack the knowledge about the specialized need of the critically ill. Now, furthermore, and I think a lot of dietitians can relate to this, is when they looked at what was happening from a feeding perspective, they noticed a trend. So as you can see, 17 patients came from the ICU to the ward and 9 of those had an NG tube in situ. 2/3 of them had that NG tube removed within 48 hours of arrival. And again, this was prior to an RD assessment, and you can see the documented rationale here, which unfortunately I know is very common, and I'm sure a few of you are chuckling out there because this happens so frequently. Now, Judith Merriweather also identified some other barriers to eating in this group of patients, and this is what she related, or she really summarized by coining the term sort of the dysfunctional body, as well as noted some of the sociocultural changes in relation to eating. So what can we do as clinicians? And I think one of the things that many might be thinking is that I've presented a lot of evidence here, and where it's really tempting to come to the conclusion to say we need to make a larger effort to delay discontinuation of enteral nutrition or nutrition support in order to enhance intake. However, we need to proceed with caution. So first of all, right now we do not have a lot of evidence to say that continuing to feed patients by enteral nutrition will improve patient-centered outcomes, such as physical function, particularly in the absence of other physical rehabilitation. Secondly, findings from a recent chart review I've just completed have shown that patients who continue to receive enteral nutrition beyond 48 hours of extubation have a significantly greater hospital length of stay, and this translates into increased costs and resource utilization. So that is a problem that needs to be acknowledged. And then we also need to consider the risks versus the benefits. Now, for patients receiving NG tube feeds for prolonged periods, and this includes small bore tubes, there is a risk of negatively impacting swallowing function. Now, for G-tube insertion, it does have an inherent risk, even if minimal, but most importantly, we need to consider and factor in what is acceptable to the patient or the impact that interventions such as G-tube insertion could have on the patients, particularly from a mental health or sociocultural perspective. So it's not just so simple as keeping those feeding tubes in. So what can we do? I've listed a number of food-focused strategies here. I'm not going to go over them, but I do want to say, again, I think we really need to start placing more of an emphasis on protein versus versus calories, considering these patients are so protein depleted. In the interest of time, I'm not going to go through this slide, only to say that there have been a couple studies that have shown enriching regular foods with protein do result in increased protein intake. So in conclusion, I really want to emphasize again that improving nutrition recovery in this group, it takes a village, and there's not a straightforward approach or any easy solution. In addition to the interprofessional healthcare team, we really need to engage family members and their caregivers, which includes providing education about what they might expect and the importance of high-quality nutrition. We also need to individualize care, and as dietitians need to be mindful of these other factors and issues in recovery that these patients are dealing with, and that nutrition just simply might not be their priority when so many other things are going on. And the development of care pathways and checklists can also be helpful. And a reference here that I've provided at the bottom of the slide actually provides a nice example of a checklist. But again, remember, any checklist should be institution specific. And then lastly, as I know all dietitians do, we really need to continue to advocate for our patients and ensure that nutrition care doesn't fall off the radar. So with that, I'd just like to acknowledge all of my collaborators. A few specific shout outs to Jill Pacole, who's a dietitian who really helped make this research possible, and Emily Chi-Yan-Yun, who was a research assistant and helped me with weighing all the food records, which was a long and laborious process. So, and then of course, the patients and families, without them, none of this research could have been done. So with that, thank you very much for staying online, and I'd be happy to take a few questions.
Thank you very much, Lesley, and it was a pleasure to hear some of this new data that you presented, and rather exciting, as you said, to see how it mirrors what we've been seeing in the small body of literature on this topic. So as Lesley mentioned, we are now going to begin answering questions, and you can ask questions at any time using your control panel. So one question we have, Lesley, is the FGA really appropriate and validated in ICU patients, invented ICU patients?
So that's actually an excellent question, and an interesting question that I've also had. So no, currently SGA has not been validated specifically for critically ill patients, and as part of the prospective study that we've done, we also included a feasibility study on examining the feasibility of doing various methods to assess nutritional status, including anthropometrics, hand grip strength, etc. And we excluded SGA because at the time of ICU discharge or liberation from mechanical ventilation, it's difficult to do SGA when you think of, well, their recent intake. Well, some of them, have been on enteral nutrition for a long period of time. They've had physical dysfunction. Again, you're relying on proxy reporting. So I would dare throw it out there to say that for this particular patient population at this particular point in time, SGA would not be the best method to assess nutritional status. However, all of the components of SGA are still important when assessing the needs of any patient. So whether it's looking at intake, looking at function, looking at body composition, and we do know it's very hard to assess body composition in this patient population, then there's certainly a need for more bedside point of care methods that can more reliably and accurately measure body composition, particularly muscle mass. So I think that's an excellent question, but particularly, again, I don't think SGA is the best in this group.
Okay, thank you. Another question is, can you describe what a critical outreach team is, or who would be on a critical care outreach team?
That's a great question as well. So an example of a critical care outreach team might be a group of, so for example, at the hospital that I was doing my research at, they always had a nurse on call who worked as part of this. They called it the CCOT team. And these individuals are present on the ward, and they're made aware of patients who prior to coming to ICU might be decompensating on the ward and might need to be transferred into the ICU. But then also following ICU discharge, they continue to sort of keep an eye on these patients to see how they're doing on the unit. And a lot of times it relates more to, respiratory status, overall health status, how are they recovering? Some might be at higher risk of ICU readmission. So it's really having this care team that tries to follow these patients throughout that transition of care. So I think there's various degrees of what these care teams may look like. So I hope that helps answer the question.
Okay, thank you. And I'll take one last question here, and it's, if you were returning to clinical practice tomorrow, what sort of the first thing you would focus on thinking about, your research and the implications it has?
That's a good doozy of a question. I think, I think there's a couple of things. The first part would be, I worked as a medical surgical dietitian, and for me, being able to engage in research, the first thing was really, I learned that some of the things I saw on the floors, patients who I often thought, it seemed like they had hospital-acquired depression was the way I was sort of thought about it, and these patients weren't moving, they weren't eating, they were becoming depressed. And so to come back to research and say, hey, there's actually a syndrome that has defined this and this exists, was something really enlightening. So I think in terms of coming back to clinical practice, the first thing, again, is highlighting how vulnerable the recovering critically ill are, and that if they're coming from an ICU, that we need to consider that this actually is a really high group of patients. Now, of course, we all have to be practical and recognize our caseloads are very high, but I think that's the first piece. The second piece, again, is really, trying to incorporate more tools to assess body composition, and I think what's been great with the CMTF work, even though SGA isn't great, particularly in this population, there's been such an emphasis on starting to do more measurable or more measures of nutritional status in our patients, because often I don't think we really, beyond saying they're mild and moderately malnourished, actually took a deep, hard look. And furthermore, I think from a food perspective, starting to work more with food services, knowing that every single hospital will have different resources, different programs, but trying to work with your department to see, okay, how can we optimize these menus? What can we do where it won't enhance cost, to see if we can start providing food that might be better for these patients. And that's a tough sell, certainly, especially because so much food is wasted. So those are just some of the things I would think of, but I think being aware alone is a big first step.
Well, on that note, you've given us a lot of food for thought, pun intended. So I want to thank you, Lesley, for this great presentation today, and thank you everyone who's joined into the webinar. And I understand that there has been difficulty accessing the handouts, so we've been working behind the scenes with our webinar provider, and those who've registered today, you will receive a link to today's handouts in a follow-up email within the next 24 hours. In addition, you will receive a short survey. We would really appreciate your feedback. And on behalf of Nestle Health Science and our presenter, Lesley Moisey, thank you once again for joining us today, and have a great rest of your day. Bye, everyone.
Thanks, Bethany.